guys, welcome back. Today we'll be talking about the pharmacology of respiratory disorders. The respiratory disorders that we'll cover today include asthma, COPD, allergic rhinitis, and then if we have time, pulmonary hypertension. All of these respiratory disorders are associated with cough, and the first two are associated with shortness of breath. And this cough and shortness of breath are typically the presenting complaint, especially when the disease is early in the progression. Asthma affects over 235 million patients. It's a very, very common disorder. Asthma is a chronic disorder that's associated with hyperactive airways. So bronchioles that constrict, they bronchoconstrict too much, which blocks airways. So this leads to episodic obstruction of airflow into the lungs. Asthma is frequently underdiagnosed and undertreated, which is why it's so important to understand how to appropriately treat it so that you can improve your patient's quality of life. COPD is also a chronic condition. COPD leads to progressive airflow obstruction. And the fact that it's progressive is very important because COPD ends up being fatal. COPD is the fourth leading cause of death worldwide, and the numbers of patients with COPD are growing. It's predicted to be the third leading cause of death at some point in this next decade. COPD is also one of the leading causes of hospital admissions and readmissions, which points to the fact that COPD is also undertreated. Allergic rhinitis is a chronic condition that's associated with red, itchy, watery eyes, a runny nose, and a non-productive cough. While allergic rhinitis isn't as severe as the other two conditions that we'll talk about, it does affect patients' quality of life. All of these diseases that we'll talk about are associated with decreased quality of life in the patient. All of them are also going to be treated with a two-prong approach of lifestyle modifications as well as medications. When we talk about delivering drugs for all of the respiratory disorders, drugs can be delivered in various ways. Drugs are frequently delivered topically, so to the nasal mucosa in allergic rhinitis, or we give drugs via inhalation, so they're delivered to the airways and the lungs in asthma and COPD. We also can give drugs via the mouth, right, orally, and we can give drugs parenterally. When we talk about treating asthma and COPD, because drugs are most frequently given via an inhaler technique is very important. So it's going to be important for you to understand how to use the different types of inhalers so that you can show your patients and counsel them on the appropriate way to use each inhaler. We'll start by talking about asthma. Asthma is an acute inflammatory disease of the airways that leads to airflow obstruction due to, again, acute bronchoconstriction. This bronchoconstriction blocks airflow into the lungs in an episodic fashion. These episodes, right, when the bronchoconstriction occurs, are what we would refer to as an asthma attack. This airflow obstruction or constriction of the airways occurs because of numerous different kind of physiologies. One, there's contraction of the bronchial smooth muscle. If you look over here, the bronchial walls have smooth muscle present in them. If that smooth muscle contracts, obviously it's going to decrease the size of the airway, so less air is going to be able to get through it. There's also underlying inflammation of the bronchial wall that occurs. Inflammation of the bronchial wall is going to lead to a thickening of the wall, as you see down here at the bottom. A thickening of this wall, which then further decreases the size of the lumen. So we have constriction that decreases the size of the lumen, and then inflammation of the wall that further decreases the size of the lumen. Because of this inflammatory process, there's also an increase in mucus production. So we have very little room for the air to go through, and now we're going to increase the amount of mucus that's in there. That's all this yellow that you see in this picture, and that's going to even further block airflow into the lungs. This underlying inflammation that occurs in asthma leads to an airway hyperresponsiveness to different triggers. Whereas in normal patients, they can be exposed to different triggers like dust or animal dander, and not have an asthma attack, not have this hyper-responsive bronchoconstriction that occurs. But in patients with asthma, the airways are hyper-responsive. This hyper-responsiveness leads to airflow limitation, as well as the respiratory symptoms that we see. The respiratory symptoms are shortness of breath, cough, chest tightness. Come on. Wheezing, and tachypnea. Which is just increased rate of respirations. When we look at asthma, asthma is not a progressive disease like we see with COPD or cystic fibrosis. It is what we would call, again, episodic. However, if asthma is untreated, this constant unaddressed inflammation can lead to pulmonary remodeling. And that pulmonary remodeling can worsen the severity of exacerbations and the frequency of exacerbations. So it is important to properly and adequately treat asthma, to try and decrease the number of exacerbations as much as possible, to try and decrease that underlying inflammation as much as possible, so that you don't have remodeling that occurs. Again, we said that there's this hyper-responsiveness in asthma, and that hyper-responsiveness occurs in response to triggers. Triggers specific environmental things or specific physiologic things that stimulate asthma attacks. Triggers are different in different patients, but triggers include things like exposure to allergens, exercise. Some patients have exercise-induced asthma, stress, and respiratory infections. The goals of therapy in asthma are to reverse and prevent airway inflammation. That's really important because inflammation is problematic in multiple ways. One, when the airways, the walls are inflamed, that decreases the lumen size of the airway. So that leads to airway obstruction in itself. So reversing that inflammation opens up the airways so the patient can better breathe. That decreases their symptoms. Also, the inflammation is what causes the hyper-responsiveness of the airways. So by preventing and decreasing that inflammation, we can prevent or decrease some of that hyper-responsiveness to triggers that occurs. Also, chronic inflammation is what leads to the structural changes in the airways and in the lungs, and that is what decreases lung function over time. So if we decrease and prevent inflammation, we're really kind of helping all of the different issues that we see in asthma. So anti-inflammatory agents are really, really important when we look at asthma. This is why we use inhaled corticosteroids. ICS is inhaled corticosteroid, like formoterol, not formoterol, but fluticasone. Fluticasone is an inhaled corticosteroid that we use, but these are there to prevent and decrease inflammation. We use medications in order to decrease the frequency and intensity of symptoms. This improves the patient's quality of life. We prevent exacerbations. We want to make sure the patient's lung function is optimal so they don't get into these severe asthma exacerbations that end up, with the patient being hospitalized or really, really ill. And then we want to minimize limitations in activity. We want to make sure patients are able to exercise, that they're able to play sports, that they're able to go for a walk outside. These are all healthy activities that patients should be able to do. When we treat asthma, the treatment is based on the classification or severity of the disease. If you look at this chart here, asthma can be classified as intermittent, mild persistent, moderate persistent, and severe persistent. And treatment escalates as we go on down each step. We add drugs on board or we give higher doses of drugs. Keep in mind that all patients with asthma should have a quick relief medication. So a medication to use in acute situations when they have a bronchoconstrictive episode, right, what people would call an asthma attack. They needed a quick relief inhaler to use right then to open up the airways. So if you look over at the treatment phase here, you'll see long-term control and quick relief. Long-term control is like chronic therapy, right? This is daily therapy that patients use. Quick relief of symptoms is acute. That is only when needed. And that's a really important distinction. It's very common for patients to misuse their inhalers or to think that their long-term control medications they should only use when they need them. But that's not the case. These are chronic medications. They are to be used daily. It's the quick relief inhaler that's only to be used PRN or as needed. Again, very important distinction. So all patients with asthma should have a quick relief inhaler. This is typically with a drug class called short-acting beta agonists, or SABA for short. Short-acting beta agonists cause bronchodilation by stimulating the beta-2 receptors. They cause bronchodilation and open up the airways. We'll talk about these momentarily, but albuterol is the most commonly used short-acting beta agonist. If you look down here, though, you'll see that there is an alternative that patients can use instead of a short-acting beta agonist. In the more severe forms of asthma, patients can use a combination of an inhaled corticosteroid and formoterol as quick relief. Formoterol is technically what we would call a LABA, a long-acting beta agonist. It's in the combination of formoterol and an inhaled corticosteroid would typically be used as a controller med, right? This would typically be used daily for long-term control. However, we see that formoterol has a quick onset of action. Most of the long-acting agents don't, but formoterol has a quick onset of action, so patients can use that for quick relief of symptoms. If you think about it, if the patient's having an acute bronchoconstrictive episode or an attack, they need relief right then. It doesn't do any good to take a medicine that's not going to work for another, half an hour or 45 minutes. But because the formoterol has a quick onset of action, it can also be used. But typically albuterol is what we'll see for that quick relief of symptoms. So looking at the different types of asthma, intermittent asthma is when patients have bronchoconstrictive episodes less than 2 days per week, and the results of their peak flow or spirometry is near normal. Near normal is classified, if you look at the bottom here, you'll see is classified as 80% or more of predicted function. So greater than or equal to 80% predicted for both intermittent and mild persistent. Patients with intermittent asthma do not have to be on a daily controller medication. They simply would have their quick relief, their short-acting beta agonist inhaler to use when needed. And then, of course, there are also lifestyle modifications, like, for example, avoidance of triggers. That would be important. Patients with mild persistent asthma still have the same lung function, but they're having more episodes. So they're having bronchoconstrictive episodes more than 2 days per week, but not daily. If they're having them daily, that is moderate persistent. Patients who have mild persistent asthma who are having episodes that frequently really do need to be on long-term controller medication. So those patients would be on a low dose of inhaled corticosteroids. If the patient's having these bronchoconstrictive episodes more than twice a week, that signifies that there's a lot of underlying inflammation and their airways are really hyper-responsive. So we need to decrease that inflammation, hence a inhaled corticosteroid. And then again, of course, the SABA for short relief, short-acting acute relief. Patients with moderate persistent asthma have daily bronchoconstrictive episodes and 60 to 80% of normal peak flow spirometry results. These patients should be on either a low-dose inhaled corticosteroid plus a long-acting beta agonist daily, or a moderate dose inhaled corticosteroid. So we're either going to increase the dose of the inhaled corticosteroid, or we're going to add on a long-acting beta agonist. And then again, they still have the quick relief inhaler. For severe persistent asthma, patients have continual bronchoconstrictive episodes, and less than 60% of normal or 60% of predicted on their peak flow or spirometry. These patients are on medium dose or moderate dose inhaled corticosteroids plus LABAs, or high dose inhaled corticosteroids plus LABA. So regardless, they should be on the combination of the two drugs, an inhaled corticosteroid and a long-acting beta agonist. And then again, quick relief. I want you guys to notice on here, nowhere does it have patients taking only a long-acting beta agonist. Okay, asthma patients should never be on, not ever, a long-acting beta agonist alone. When asthma patients take long-acting beta agonists alone, it's associated with worse outcomes and increased risk of death. So long-acting beta agonists can be helpful, but in combination with an inhaled corticosteroid. Okay, inhaled corticosteroids are the mainstay of asthma treatment. Okay, inhaled corticosteroids are the mainstay of asthma treatment. This differs from COPD. Okay, we'll see that in COPD we can give patients long-acting beta agonists by themselves, and that's okay, but that is not the case with asthma. Okay, very, very important. So first we'll talk about beta agonists. Real quick, just think about beta receptors, right? We have beta 1 receptors and beta 2 receptors. Beta 1 receptors are on the heart. When they're stimulated, they increase heart rate and increase contraction. Beta 2 receptors are present on the or in the lungs. When beta 2 receptors in the bronchioles, on the smooth muscle of the bronchioles, are stimulated, they cause relaxation of that smooth muscle. So inhaled beta agonists are beta agonists that are delivered directly to the surfaces of the airways and the lungs. And when the beta 2 receptors are stimulated, they cause relaxation of the smooth muscle in the airways. Okay, this opens up the airways and allows airflow to proceed. Inhaled beta agonists can be classified as SABAs or LABAs, right? There are short-acting beta agonists and there are long-acting beta agonists. Short-acting beta agonists, or SABAs, are used for quick relief of symptoms. SABAs include albuterol and levalbuterol. Albuterol is very commonly used. These are used again for quick relief of symptoms. They use for symptomatic treatment of bronchospasm. They can be used alone, so as monotherapy in mild or intermittent asthma. So either intermittent asthma or mild persistent asthma. Also in exercise-induced bronchospasm, which we'll talk about in just a second. These SABAs are also used in more severe forms of asthma, but not as monotherapy. They're not used alone. They're used as adjuncts, right, in addition to an inhaled corticosteroid in moderate persistent and severe persistent asthma. Remember, these have no anti-inflammatory effects. So in the more severe forms of asthma, they have to be combined with an inhaled corticosteroids. But all patients with asthma should have a short-acting beta agonist on hand or formoterol for use as needed. Adverse drug effects of the short-acting beta agonists are pretty limited with direct delivery. They are being delivered directly to the lungs. Also, there's not much beta-1 stimulation. But remember that even if a drug is specific for beta-2 receptors, it's not 100% selective. So it is possible to have some adverse drug effects that are systemic, or some adverse drug effects that have to do with the beta-1 receptor. But again, they're typically relatively minimal or relatively limited. Some things they might see include tachycardia, or patients might kind of feel like shaky, like tremors or kind of shaky afterwards. Some hyperglycemia might occur, because remember, this is like beta agonist is stimulating the sympathetic nervous system. And a result of that stimulation is that we increase the amount of glucose that's available to fuel the body because it thinks it's a fight or flight response. Now again, we're delivering the drug directly to the site of action, directly to the lungs. So not as much of it is going systemically through the body. So we really do limit these adverse drug effects by delivering the drug directly to the lungs. Typical doses of albuterol are 2 puffs. Okay, that's 2. So 2 puffs every 4 to 6 hours as needed. Okay, PRN is as needed. The onset of action is quick, okay, so 5 to 30 minutes. And really closer to this 5-minute mark. Duration is 4 to 6 hours. So 2 puffs. If 4 hours later the patient still is feeling kind of short of breath, then they can use it again. But they don't have to, only as needed. Albuterol, or short-acting beta agonists, can also be used for exercise-induced bronchospasm. So exercise-induced bronchospasm is this pretty predictable pattern of bronchospasm that occurs when someone exercises. We see this a lot with like younger kids where they go to PE at school and have a bronchospastic episode. So in this case, we give albuterol to prevent the episode. You don't wait until it actually happens in this case. You give it preemptively. So for exercise-induced bronchospasms, we do 2 puffs, 30 minutes before exercise. Two puffs, 30 minutes before exercise, because prevention's better than treatment. Long-acting beta agonists, or LABAs, include drugs like formoterol and salmeterol. These, again, are primarily for long-term control in asthma. And I'll say this again, the long-acting beta agonists are used as adjuncts to inhaled corticosteroids in moderate and severe asthma. Monotherapy, so just a long-acting beta agonist, is contraindicated in asthma patients. Okay, the inhaled corticosteroid is the drug of choice for long-term control of asthma. The beta agonist is just, the long-acting beta agonist is just added on in more severe forms of asthma. So first we tried the inhaled corticosteroid. If the patient can't be controlled on the inhaled corticosteroid alone, then we add the long-acting beta agonist, and that can be helpful. The long-acting beta agonists are called long-acting because they have a longer duration of action. They provide prolonged bronchodilation for at least 12 hours. Again, these are typically used on a daily basis. So there's drugs like Advair and Symbicort that are used chronically on a daily basis or a scheduled basis with patients who have moderate or severe persistent asthma. Also, patients with moderate or severe persistent asthma can use formoterol plus an inhaled corticosteroid for acute relief of symptoms, which we mentioned on the other slide. Adverse drug effects are similar to what we saw with the short-acting beta agonists. Corticosteroids include drugs like beclomethasone, budesonide, fluticasone, and mometasone. Corticosteroids are anti-inflammatory drugs, and we know that inflammation of the airways is a major problem in asthma. So it makes sense that controlling inflammation would control asthma. Corticosteroids, again, inhaled corticosteroids specifically, inhaled, are the drug of choice for long-term control of persistent asthma. Something to keep in mind with the inhaled corticosteroids are that they have to be used regularly in order to be effective at decreasing airway inflammation. Also, it can take a couple months for them to really decrease the hyperresponsiveness of the airways. So patients need to know this. They need to know that they have to take this regularly. Okay, so regular use required for effects. I don't know why it is that so many patients think that these can just be used whenever they feel like they need it, but it happens all the time, and I could see it in the pharmacy with like how frequently they would refill it. So that was kind of my key. If I saw that they would refill it like once every 3 months and it was supposed to last 1 month, that would be my key to ask, how are you using this drug? So make sure you talk to your patients about that, the fact that you need to use this. This is a controller medicine. It needs to be used daily. The mechanism of action of the inhaled corticosteroids are to inhibit the enzyme phospholipase A2. That decreases the release of arachidonic acid. Arachidonic acid metabolism leads to an increase in leukotrienes, and that leads to inflammation. So blocking this decreases the inflammatory cascade, so decreases inflammation. And then again, with a couple months of consistent therapy, we see that this leads to reduced hyperresponsiveness of airway smooth muscle. So again, that means that the airways don't have this severe bronchoconstriction that occurs when the patient is, exposed to some sort of a trigger. So again, like cold, for example, or exercise, or irritants, or allergens. There's just a decrease in hyperresponsiveness to any of these. So corticosteroids decrease inflammation. Corticosteroids can be given in different ways. So far, we've been talking about inhaled corticosteroids, which are what we normally use for long-term chronic therapy in asthma. The drugs that were on the last slide and the drugs that we have at the bottom here on this slide, those are all inhaled corticosteroids. The reason we give the corticosteroids via the inhalation route is because it greatly reduces systemic adverse drug effects. Long-term oral corticosteroids cause a lot of adverse drug effects, pretty serious adverse drug effects. So we really try and avoid long courses of corticosteroids by mouth. When we give them via inhalation, we avoid a lot of that. When we give corticosteroids via inhalation, technique is very important. Technique is important, one, to make sure that the patient actually gets the drugs where they need to be down into their lungs, and then also to try and minimize any adverse drug effects from occurring. Adverse drug effects of inhaled corticosteroids are very mild. They typically are pretty well tolerated. Patients can experience oropharyngeal candidiasis and hoarseness as well. So the reason is like a yeast infection in the mouth and throat. The reason that this can happen is if when the patient inhales the inhaled corticosteroid, some of the particles get shot back, into the lungs and into, the bronchi and bronchioles, but some of the particles fall out onto the tongue and onto the throat. And those particles that fall out onto the tongue and onto the throat are what cause the adverse drug effects in that oropharyngeal area. So if we reduce the amount of drug that falls out onto those areas, we can reduce those adverse drug effects. For example, we have patients swish and spit after use. And patients should always be told this. So after they use the inhaled corticosteroid inhaler, they, with water, swish their mouth and spit it out. And really before that, it's best to do first swish and swallow, then swish and spit. The swish and swallow washes the throat. Because when you just swish water around your mouth, you're not really getting down to the throat. So swish and swallow allows you to kind of rinse the throat, and then swish and spit allows you to get the last remnants of the drug out of your mouth, so that you're less likely to have the yeast infection in the mouth and in the throat, and less likely to have that hoarseness develop. Sometimes, despite adequate therapy, patients can have severe exacerbations that occur. This tends to happen most frequently when patients have a respiratory infection, but patients can have a respiratory infection and have a severe exacerbation where we see decreased oxygen saturation, bad wheezing, and in that case, we can give a short course of oral or systemic corticosteroids. So these are drugs like prednisone or methylprednisolone. Again, this is just a short course of therapy used in severe exacerbations. Because it's such a short course that's used, we typically don't see the more severe systemic adverse drug effects associated with it. Also, because it's such a short course, you don't have to taper down the dose. When we give steroids, oral corticosteroids, for a long period of time, it ends up suppressing the hypothalamic pituitary axis. So you can't withdraw them abruptly. You have to slowly taper them down so that the hypothalamic pituitary axis can recalibrate as you slowly take the steroids away. But when we give this such a short course like this, it doesn't suppress the axis, so you really don't have to taper them. I really do see doctors taper them a lot, though. It's really frequent, even if they just give it for a few days to taper the dose, but it's not necessary. You can give a short course for a few days and you don't have to taper the dose, but it won't hurt. Systemic side effects of long-term corticosteroids include osteoporosis, immunosuppression. Shorter courses, we can still see hyperglycemia, so that's something to watch out for in diabetic patients. We can see hypokalemia, so that's something to watch out for in patients who are on diuretics that might cause hypokalemia. Hypertension, peripheral edema, we see increased appetite and weight gain. The weight gain, again, is really more over a longer period of time. You're not going to see that with a really short course, not enough that matters. You can see kind of hyperactivity with a short course, though. I'm just writing hyper because I don't really have room, but hyperactivity and some kind of like insomnia we do see with oral corticosteroids sometimes. I do try and watch out with that, especially with little kids. But if you tell people when they're dosing to try and dose it in the morning, if you dose it at night, you're likely to be up all night, and your kids will kind of go crazy. Little kids with asthma, when we give them corticosteroids, they frequently get kind of off the wall. This happens with my daughter all the time. She goes crazy on it. But it's a really common thing, especially with kids. Alternative drugs are added to inhaled corticosteroid therapy in patients who are poorly controlled on conventional asthma therapy. They can also be used in patients who can't tolerate inhaled corticosteroids. But if the patient is able to tolerate an inhaled corticosteroid, then these should be added on. So these should be used together with the inhaled corticosteroid. The drugs that we see here, Xylutin, Zafirlupast, and Montelukast, these drugs are what we call leukotriene modifiers. So they modify the action of leukotrienes or block the action of leukotrienes in some way. And the leukotrienes are all related to causing like inflammation and constriction and mucus production. What you see here in this picture is like the overall inflammation cascade that happens. You can see phospholipases right here where the steroids inhibit the phospholipases in order to decrease production of arachidonic acid. You can see how arachidonic acid gets metabolized by 5-lipoxygenase, and that leads to the production of leukotrienes. There's numerous different types of leukotrienes, but ultimately the leukotrienes end up, they end up causing white blood cells to come to the area. So that's positive chemotaxis. Like you can see, they pull eosinophils and pull neutrophils to the area. They increase inflammation. They cause bronchiolar constriction. I wrote arteriolar. That's bronchiolar. Bronchiolar constriction. They cause mucus production. So they're causing all of the issues that happen in asthma. So by blocking these leukotrienes in some way, you can help prevent those symptoms. Xylutin works by inhibiting the production of leukotrienes. You can see Xylutin right here, inhibiting the lipoxygenase to inhibit the production. Zafirlupast and Montelukast work by blocking the action of leukotrienes. You can see them down here, right, blocking the binding of the leukotrienes. So again, the result here is that we prevent all of that increase in inflammation, we prevent the constriction, we prevent the mucus production. This all sounds great, but these are not as effective as inhaled corticosteroids are at preventing the inflammation and the constriction and the hyperreactivity. So they're not as effective traditionally and not as well tolerated. So they are used as second-line agents for the prevention of asthma symptoms and prevention of exercise-induced asthma. Again, typically we would add them to an inhaled corticosteroid if the patient was still symptomatic, but if the patient can't tolerate the inhaled corticosteroid, then we can try the second line instead. Adverse drug effects include increased liver enzymes, so you have to monitor LFTs. liver function tests. And if liver enzymes increase 3 to 5 times the upper limit of normal, then you need to DC the drug. Okay, so it's expected that liver enzymes will increase, but if they increase more than 3 to 5 times the upper limit of normal, the drug needs to be stopped. Drugs are also more commonly associated with mild side effects like headache and dyspepsia. Keep in mind, these are not for acute bronchodilation. Okay, these are not acute, not for acute treatment. This is long-term, daily, chronic therapy. Other alternative agents include cromolyn. Cromolyn is a drug that inhibits mast cell degranulation and histamine release, which mast cell degranulation and the histamine end up causing inflammation. So by inhibiting these things, this decreases inflammation. Cromolyn is an alternative agent that can be used for mild persistent asthma. It has a really short duration of action, which kind of limits the ease of use. It has to be dosed 3 to 4 times daily, so much more frequently than like the long-acting agents and the inhaled corticosteroids. Adverse drug effects. Again, this is not for acute use. Adverse drug effects are mild. They include things like cough, bad taste, okay, local irritation, but relatively minor. Cholinergic antagonists block the vagal effects on the airways. Think about the cholinergic nervous system and what the cholinergic response is on the airways. Blocking these vagal effects mean like blocking smooth muscle contraction, right? So blocking constriction, blocking mucus production, which is also a problem because that clogs up the airways. There are a couple different cholinergic antagonists that can be used in asthma, the short-acting and then long-acting. So just like we have short-acting beta agonists, short-acting and long-acting beta agonists, we have short-acting cholinergic antagonists and long-acting cholinergic antagonists. The short-acting agent is ipratropium. Ipratropium is has a slower onset than a short-acting beta agonist. So it's not used in place of the short-acting beta agonist in asthma attacks. We typically don't. We try not to use this in place of. We can add it on to. But a short-acting beta agonist is much better in the case of an asthma attack because it starts working faster. Okay? This has a slower onset. Ipratropium is used in asthma COPD overlap syndrome. So patients with COPD who also have a reactive airway component. It can be used in conjunction with a short-acting beta agonist in the ER. Frequently, we'll see both albuterol, so ipratropium plus albuterol used in a nebulizer, so nebulizer solution. In patients who end up in the emergency room with an exacerbation, you can sit them down and get them the nebulizer solution with both a short-acting beta agonist and the short-acting cholinergic antagonist. Long-acting cholinergic antagonists include tiotropium. Again, this is an add-on in adults with severe asthma with a history of exacerbation. So again, notice add-on. This isn't replacing other therapy, but this is being added on. Adverse drug effects include xerostomia, which is just dry mouth, and a bitter taste. Dry mouth makes sense, right? Because this is anticholinergic. It's blocking the cholinergic system. A couple other types of drugs that aren't used as commonly include theophylline. Theophylline is a bronchodilator that used to be used a lot more for chronic asthma. It's an oral medication, but it's just kind of a messy drug to use as an older drug, and it's really been replaced by beta-2 agonists and inhaled corticosteroids. It has a narrow therapeutic index, which you guys know means there's not very much difference between the therapeutic dose and the toxic dose, and because of that, it requires drug level monitoring. It also has a poor adverse drug effect profile. It can cause seizures, it can cause arrhythmias when levels are high, so it is problematic when drug levels get on the high side. There's also numerous drug interactions, so it's just kind of a pain, and there's no really reason to use it when we have other agents available that are effective. But it is available. If you try other agents and you're not able to get a good enough response, the patient continues to have bronchoconstriction, you can try theophylline. Monoclonal antibodies are used for severe persistent asthma that's poorly controlled on conventional therapy. On the next slide, I'll kind of talk to you about the different types of asthma that this might be. But if a patient has severe persistent asthma and you're giving them all of the normal drugs that we would give them and they continue to have exacerbations, then it's likely that they might have an atypical form of asthma. They might have an asthma that's like eosinophilic asthma or allergic asthma, where there are other mediators at play. And in that case, we might need to treat them a little bit differently. So these drugs, these drugs are monoclonal antibodies. So omalizumab is a monoclonal antibody that inhibits IgE. IgE, remember, is important in allergic responses. It's important in allergic responses. These other agents, mepolizumab, reslizumab, benralizumab, are interleukin-5 antagonists. Interleukin-5 is important in the recruitment of eosinophils. So these would be important in eosinophilic asthma. These agents are frequently limited by cost. The use is limited by cost. They're extremely expensive. Route of administration, when we look at how they're parenteral, they're not taken by mouth. Reslizumab is IV. The other agents are sub-Q, which is harder than oral medications. Adverse drug effect profile is harder. These aren't the types of drugs where you would just write a prescription, hand it to the patient, and that's it. They go pick it up from the pharmacy. There's programs where the nurse has to call, they have to go through all this paperwork, they have to figure out the insurance or patient assistance programs, and then it gets given to the patient. It's a whole ordeal. So these typically would be prescribed by a pulmonologist. Which brings me to this last slide. Asthma type 2. Asthma type 2 is asthma that's characterized by type 2 inflammation. There's all different types of inflammation, and the different types of inflammation are kind of mediated by or characterized by different inflammatory markers. Patients who are not responsive to inhaled corticosteroids and who aren't responsive to normal therapy might have a different type of asthma. They might have a different type of inflammation occurring that's mediated by different cells and different compounds. So we might have to treat that a different way. that's why on the last slide we said, that we might use these monoclonal antibodies in patients who have severe persistent asthma that aren't responding to the drugs that other people respond to. They're not responding to what we normally use. When a patient is, so these other mediators, okay, we might see like high eosinophils, IgE, interleukin 5, interleukin 13. These are things that we'll typically see increased levels of, like IgE and eosinophils. The interleukin 5 and interleukin 13 are important mediators in this type of inflammation. So upon asthma diagnosis, you can test your patient, especially for eosinophils, to look at their eosinophil count. You can test for IgE, but especially eosinophils. And if you see that the eosinophils are high, at that point you know that this is probably more complex than a general PCP is going to be handling, because the PCP is handling everything else as well. So at that point, you should refer the patient to a pulmonologist. If the eosinophils are high, that typically says that we have eosinophilic asthma. If high IgE, there's probably an allergic asthma, which involves a whole other workup as far as, skin prick testing, and there's a whole ton that's involved in diagnosing a specific type of asthma and figuring out the treatment for that type of asthma, and then following up with the treatment of that asthma. So again, if you see that the patient has a high eosinophils, it's best to just refer them to a pulmonologist to handle. Or if you have a patient with severe persistent asthma and you're treating them with everything you can and they're not, they're still having exacerbations, at that point refer them to a pulmonologist, because this is what the pulmonologist is going to do. All right, I'm going to go ahead and end this lecture here at the end of our asthma discussion, and then the next video I'll go ahead and do COPD.